Good afternoon, everyone. So we are here today for the fifth lung cancer masterclass, and this is the third day of this masterclass, and we are here to discuss issues about the palliative care in the lung cancer segment. So I am Dr. Raghu Thota. I am a professor in palliative medicine, and I am here with my team who does a lot of oncopalliative work and a lot of pain interventions, which also includes non-cancer pains. Okay, so I would like to welcome here Dr. P.N. Jain, who is a professor of palliative medicine or Department of Palliative Medicine, Tata Memorial Hospital, Mumbai. He will be on. He will be joining us online. Then I have with me Dr. Shiv Pratap Singh Rana. He is a consultant, Department of Palliative Care and Pain Management from the Bahrain Oncology Centre, King Hamad University Hospital, Bahrain. He has come all the way from there. Thank you, Dr. Shiv, for joining us. And then we have Dr. Sadashivan Iyer, who is a consultant in pain management and anesthesiologist, Manipal Hospitals, Bangalore. We also have Dr. Avinash Bundiwal, who is a very enthusiastic, young, energetic pain physician. He is a director and pain consultant of Janseva Clinic and Ayushman Hospital, Ujjain, MP, Madhya Pradesh. So I welcome you all over here, and I would like to also thank the delegates who are here in presence, as well as those who are joined me online. So to start with this program. So here we will be discussing, mainly we are focusing in palliative care, we will be focusing on the pain management issues. That's the one symptom we thought we will discuss. And in that also, we will be focusing mainly on the interventional aspects of this lung cancer pain management, rather than pharmacological managements and non-pharmacological managements. So there are various interventional pain managements. So before going into or delving into these interventional pain managements, I thought it will be prudent to discuss the pain syndromes in patients with lung cancers, because unless and until you don't know what the patients are presenting with, which type of pain syndromes they are presenting with, it will be very difficult for you to treat as a palliative care physician and as a pain physician to these patients, because lung cancer pain is a very severe cancer pain, and there is a lot of disability which happens to the patients, and their quality of life is really hampered. So coming to that, so I had thought then after discussing these pain syndromes, so we will talk about the interventions. So we have classified these interventions as the peripheral interventions and ultrasound guided interventions, even though peripheral interventions are done by ultrasound. So peripheral nerve injections will be spoken by Dr. P.N. Jain. So he will be talking mainly about the paravertebral nerve block, and he will be talking about the intercostal nerve blocks. Then we will talk about ultrasound for musculoskeletal pain in lung cancers. So most of the musculoskeletal pain which happens in the chest area as well as the shoulders. So Dr. Avinash will be speaking on that. Then Dr. Shiv Pratap Singh Rana will be speaking about the intrathecal drug delivery system and kyphoplasty. These are a bit of advanced intervention pain managements, and Dr. Shiv is a very dynamic and a very experienced, I can say, pain and palliative physicians who manages this type of interventions in this group of patients. Then last not but the least, we will be speaking about the interventional pain management outcomes and the clinical predictors, because this is very important, because without knowing that, just doing an intervention and we don't know what will be the outcomes and what are the real predictors which will improve our outcomes. So I thought this will be a very interesting topic, and Dr. Sada Shivan Iyer has taken this responsibility to show us an insight into this aspect. And then we have a panel issue about whether the palliative physician should be doing these interventional pain management procedures. So we will be discussing about who will be doing this, why they will be doing this, when they will be doing this, and how they will be doing this. And I will be moderating that. And the entire faculty will be the panelists for the issues. So coming back to my lecture. So we will be speaking about the pain syndromes in patients with lung cancer. So as everyone knows, lung cancer is a solid tumor. So we usually classify the tumors as a solid tumor or liquid tumors or hematolymphoid tumors. So lung cancer comes into the classification of solid tumors. So everyone knows that the pain originates within the thoracic cavity, mainly because of the primary tumor itself, or because of the metastasis of the neoplasm, that the same tumor which may metastasize, or from other areas it may come to these areas. And it involves the lungs, the heart, esophagus, neural structures such as the brachial plexus and intercostal, then your osseous structures and or lymph nodes. So these are the various ways the lung cancers do present with, and these are the various sites. So you have to remember that this pain in lung cancers is multifactorial. It's not only one factor. For example, if he is having just a tumor, for example, in the lower lobe or right lower lobe, okay, so he may have pain there because of that segment itself. Okay, he may have pain because if the pleura is involved, or if the ribs are involved, or if it is metastasized to his dorsolumbar spine, he may have pain in the back. So it's not only one pain generator. There are many pain generators which are involved when the patient do present with a lung cancer and pain. So we have to really understand these aspects before just considering as one factor, because whenever we are doing interventions, it is a very important aspect, because it is not the indication, it is the selection which is based. The selection improves the outcome rather than the indication. So though the lung cancer patients typically have a variable cancer pain presentations, as already mentioned, the chest and the lumbar spine are the most frequently involved areas. So mainly the patient presents either with a chest pain or the back pain. So the chest pain is mainly because of the lung itself, and the back pain, it is because of the bone, skeletal metastasis. So these are the things the patients do present with. So one more thing I have highlighted here is this in red. So we have to understand is that it is not only the primary tumor. Okay, so a primary tumor may be from other place. For example, if it is a breast cancer, it may metastasize to the lungs. Okay, the colon cancer can metastasize to the lungs, and that may cause a pain in the lung or in the thoracic areas. And we might be thinking, it could be a CL lung. No. So these things also play a very important role, and we need to understand that metastasis from other places may come to lung and can cause pain. Okay, so that's why I thought I will highlight this sentence. So metastatic lung lesions are present in as many as 30% of patients with all cancer types. So commonest are the colon and the breast cancers. So they usually metastasize to that areas. So in a nutshell, if you talk about the common causes of pain in patients with lung cancer, so we can classify as intrathoracic causes and extrathoracic causes of pain. So intrathoracic, so it usually the chest pain, it could be because of the pleural invasion, chest wall invasion, okay, pulmonary embolus, costopleural syndrome. We will discuss all these things one by one as we go in our presentation. Then we have extrathoracic causes of pain, metastasis. So especially the bone metastasis. Almost 30% of the patients do present with bony metastasis in lung cancers, and especially the metastasis are to the dorsal spine and the lumbar spine, and they do have pain, the resting pain as well as pain during movement, coughing and walking. Then they also metastasis to the liver and to the brain, and they present differently. We will speak about that. They also present with hypertrophic osteoarthropathy, and also this could be due to because of the paraneoplastic syndrome. Also, they are also present with the joint pains, mainly because of certain monoclonal antibodies which are given in this group of patients, or certain immunotherapies, or tyrosine kinase inhibitor group of medications which are given. They cause a lot of osteoarthritis, and the patients do become debilitated sometimes. So now one by one, we will go into each of these pain syndromes. So what are the various pain syndromes? First is a visceral pain syndrome. Since we're focusing mainly on the lung cancer, so it is a thoracic visceral pain syndrome. Then the second is the thoracic nociceptive pain syndrome. The third is the malignancy associated neuropathic pain syndrome. And the fourth one is the treatment associated pain syndrome. So we will be discussing all these in details. So coming to the first, that is the thoracic visceral pain syndrome. So as the name suggests, it is because of the viscera. So what is the viscera? The main viscera is our lungs, which are there in the thoracic cavity. So there can be a lung cancer in this patient. So almost the pain, it occurs in up to 80% of the patients in this group of patients who has a lung cancer, they present with the chest pain. Okay, or they also present with an ipsilateral shoulder pain, and also present with a cutaneous hypersensitivity of the T2 to T5 dermatomal distribution. Suppose if it is involving your intercostal nerves. Then the cardiac tumors, even the heart is situated in the thoracic cage. So it is a very rare tumor, a rare presentation cardiac tumors, but just for the completion's sake of thoracic visceral pain syndromes, I have involved this. And here you see that there is a referred pain to the non-diseased areas. So the cardiac pain will never present with, even you know that even in the angina, though there will be a chest pain that it usually radiates to your left shoulder or your left upper limb. So it will be a referred type of pain, and it is very difficult to treat such pain. So whenever there is a referred pain, it is a very difficult pain to treat by intervention. So you have to remember this. Then we have thoracic nociceptive pain syndromes. So what are the different thoracic nociceptive pain syndromes? There are 7 types of nociceptive pain syndromes. Primary chest wall pain. Then we have Pancreas syndrome. We have superior vena cava obstruction syndrome. Then we have skeletal metastatic disease. Then we have C7 to T1 syndrome. We have base of skull metastatic disease. And then we have paraneoplastic syndromes. So these are the 7 types of syndromes which are classified under thoracic nociceptive pain syndromes. Okay. Why we are calling it as nociceptive? Because it is a somatic type of nature and it involves a nociceptive receptors. It's not a mixed type of pain. Your nerves are not mainly involved in this type of pain. So what is the primary chest wall pain syndrome? So it ideally results from the malignant invasion of the ribs, your intercostal spaces, adjacent soft tissue structures, or parietal pleura. So because of this, you may have pain, and the most common with lung cancer and mesothelioma. You have to understand that mesothelioma is such a dreadful, painful situation. The patient with mesothelioma, ideally, though, most of the times we need to give some intrathecal interventions rather than just giving superficial intervention. So such severe and such intractable and refractory pain this group of patients have. Then patients are often more comfortable at rest and commonly suffer from acute breakthrough pain with deep breathing or coughing. So this you have to really understand this, because breakthrough pain in cancer pain, it is very, very important aspect you have to understand. Even though there is a baseline pain and it is well controlled, sometimes the patients do present with certain acute episodes of pain which are from moderate to severe intensity and for a short duration of time. And it really is debilitating to the patient, because, for example, if he needs to walk around or if he needs to do certain exercises, then it really hampers his rehabilitative procedures. And also, again, it is very important because even the caretakers are affected here because they just can't see the agony, and this really affects them also, the caretakers who are taking care of these patients. Second one is the Pancreas syndrome. And as everyone knows this, we have been reading from first MBBS, what is Pancreas syndrome. And it is especially the apical chest wall. It involves apical chest wall with resulting mass effect on the adjacent structures, including the lower part of the brachial plexus, upper ribs, vertebral bodies, subclavian vessels, or sometimes the stellate ganglion also. So mainly it is always the upper lobe. The middle and the lower lobe usually doesn't present with the Pancreas syndrome. We have to understand this. Okay, and the patients often present with the severe and progressive ipsilateral shoulder pain. Sometimes they do present with Horner syndromes if there is an involvement of your stellate ganglion, and upper extremity edema. Pain also often refers to the neck, axilla, or medial aspect of the arm. Coming to superior vena cava syndrome, it results from a mass in the middle or anterior mediastinum. The superior vena cava obstruction also happens because of the intravascular devices, most commonly the stents, or most commonly the PICC. Okay, most of our chemotherapy patients do have PICC or Hickman's catheter. So it can happen because of that also, the superior vena cava obstruction, or even thrombosis without an extrinsic compression. So they do present with various symptoms, but since we are speaking here, our main focus is the pain. So they do present with headache. That is what is the main concern. And there is an increased swelling in the neck and arms. There will be dyspnea, sometimes dysphagia, or even mental status changes secondary to cerebral edema. And usually the treatment consists of steroids, vascular stenting, or radiotherapy. So this is the commonest one, along with your anticoagulants, which we can give to this group of patients. Then skeletal metastatic disease. This is a very, very important topic. Not only in lung cancer, in any type of cancers. If the patient has skeletal metastatic disease, it is usually the metastatic bone pain, we call it as MBP. It's very common. Okay, and it is almost 30 to 40% of the patients develop bony metastasis in lung cancers. And pain is always the initial presenting symptom, almost 80% of the time. There is a functional impairment and loss of independence, because this really adds on to the suffering. And as palliative physicians, our role is to decrease this. Okay, we have to increase their independency, we have to decrease their functional impairment. So that is our sole objective of this specialty. And because we are just symptom managers, and that is what we have to do, give them a good quality of life to this group of patients. So malignant bone pain is thought to have many components like neuropathic pain, inflammatory pain, and sometimes they do also have an ischemic pain component. Again, here, breakthrough pain, background pain, it usually responds to the analgesic therapy. Okay, and the breakthrough pain, it persists for a very short amount of time in this group of patients. So one more thing you have to understand is that in metastatic bone pain, we use something called as bisphosphonates or denosumab. There's a RANKL blockers. And even though if the patients are not having pain, you might have seen most of our medical oncologist colleagues, they do prescribe a monthly zoledronic acid bisphosphonate, even if they don't have pain, to prevent something called as SREs. What are SREs? They are skeletal related events. That is the pain. One of them, it is the pain. Second is the compression fracture leading to your spinal cord compression. Okay. Third thing, hypercalcemia. So these are the things we really need to prevent. Okay, so that's why they give bisphosphonates or denosumab. Denosumab is a very expensive thing, but zoledronic acid is the cheapest one, around 700 rupees per month. So that it's not that it will 100%, but they delay the onset of the SRE, skeletal related events. So even though if they are not having pain, we can, I had to start them with bisphosphonates or denosumab therapy to prevent these skeletal related events. And if you see, compared to bisphosphonate therapy, denosumab is superior. But we really need to understand whether the patient, means the cost benefit ratio, we really need to understand with each individual patient. So if they are affording, yes, you can go with denosumab. There is no harm in that. Again, we will be speaking about vertebral augmentation. My dearest friend, Dr. Shiv, will be speaking about that. He will be speaking kyphoplasty. So vertebral augmentation techniques are used to significantly reduce the pain in cancer patients with metastatic spinal fractures who are unresponsive to conventional conservative opioid therapies. And our radio-oncology colleagues also give radiation therapy. Either it could be a single fraction or a 3 fraction or a 5 fraction radiotherapy to this group of patients. Ideally, if you ask me, for the metastatic bone pain, the radiation therapy is the gold standard. And then if it is not helping, and if there is a fracture and all, or if we think that the patient is going to get these things, we can do vertebral augmentation therapies. Now there is something called as C7T1 syndrome. Now it happens because of the hematogenous spread of the cancer from breast or bronchus malignancy especially. So the bronchus malignancies, they involve the C7 and T vertebral levels. And they complain of aching, constant pain, unilateral radicular pain in C7 to T1 distribution, especially the medial aspect of the arm, triceps weakness, and sensory changes in the 4th or the 5th digits. If you see, this same distribution also happens in something called as our Pancreas Syndrome, because even the Pancreas Syndrome also involves your lower brachial plexus rather than the upper brachial plexus. And we will come further. There is something called as radiation-induced flexopathy also, which involves your upper segments rather than involving your lower segments. We will discuss that. Okay. So any patient with a known or a suspected malignancy and progressive pain in this area should be evaluated for this pathology. So you just can't leave them like that. So if they're coming to you, it should always. And one more thing I would like to enhance here, because I think online, even most of the pain physicians might be listening to us, that whenever the patient comes to you for a pain, unless and until he's evaluated outside for red flags, please do evaluate for red flags. And one of the red flag is cancer. But anyway, we are working in a cancer institute, so that is out from ours. But still, it is very important as a pain physician, we need to evaluate for the red flags in any group of patients who are presenting with pain. So base of skull metastasis, it can metastasize to that area. Patients most often complain of headache with paresthesia and sensory changes in the distribution of one or more of the cranial nerves. And the most common which we can have is a jugular foramen syndrome. So what happens in this group of patients is there is a pain in the ipsilateral neck. If you see the jugular foramen, if you really remember your anatomy, right, there's a glossopharyngeal nerve which comes through that area. All right, there is a spinal accessory nerve which comes through the jugular foramen. So that's why anatomy is important. Okay, so they have this ipsilateral neck pain, shoulder pain, mastoid region pain, hoarseness, dysphagia. Okay, and sometimes this at the base of the skull, the metastasis may involve your vagus nerve, and the patients do sometimes present with bradycardia. So it's very important to really evaluate such group of patients who present with bradycardia. But I can say that we are lucky enough as a palliative physicians that most of the patients are evaluated and then they be referred to us. So I can say that almost 100% at present, till this date, ours is a referred specialty. So most of the times means always they are evaluated, not even most of the times. So this is what they present with the jugular foramen syndrome. So then paraneoplastic syndromes, this is very important because it causes a mixed sensory motor peripheral neuropathy. There will be pain, paresthesia, nociceptive, and sometimes proprioceptive loss is also associated with hyporeflexia or areflexia. It may also sometimes, this paraneoplastic syndrome, it involves wherever there is no, it will involve that areas. Okay, so it can also involve your DRGs, it causing dorsal root ganglionitis, necrotizing myelopathy, but it is rare. But they are very painful paraneoplastic syndromes. It also causes hypertrophic pulmonary osteoarthropathy, sorry. And it presents like rheumatoid-like polyarthritis affecting your knees, wrists, and ankles. Again, you have to remember that in lung cancers, we also use most of these immunotherapies or most of the monoclonal antibodies. They also cause rheumatoid-like syndromes, osteoarthritis, especially the durvalumab, the drug, which causes a severe joint pains, knee joint pains. So the treatment usually consists of your anti-neuropathic agents, analgesics, but pain symptoms infrequently improve without successful antineoplastic. So antineoplastic therapy is important, and that do really take care of this group of patients. Okay, and one more thing you have to remember, that if the paraneoplastic syndrome affects the peripheral nerve systems, it is treated much better than the central nervous system pathology. Then coming to the malignancy associated neuropathic syndromes. So what are they? Intercostal neuropathy, brachial flexopathy, suprascapular entrapment, facial pain, spinal cord compression. So these are the things which I will be discussing in this malignancy associated neuropathic pain syndromes. So coming to first, the intercostal neuropathy. The most frequent cause of the intercostal nerve damage, it can be because of the post-herpetic neuralgia. Most of the patients on chemotherapy are immunosuppressed and they are very prone. Almost 15 to 20% of the patients do get post-herpetic neuralgia, herpes infection who are on chemotherapies. It can happen because of the thoracic surgery, okay, but also the lung malignancy, rib compression, and pleural mesothelioma are the commonest things which can cause these things. They present with neuropathic pain in cutaneous hypersensitivity disease. This is a classical neuropathic pain symptoms they present with, and altered touch discriminations in the same distribution. That is allodynia, hyperalgesia, hyperpathia, all these things. Brachial flexopathy is the apical lung tumors, and they invade the lower aspect of the brachial plexus. And you see the neuropathic pain is in the axilla, the medial aspect of the arm, same like the C7T1 syndrome. Distribution of the ulnar nerve associated with weakness and atrophy of the intrinsic hand muscles. This is an additional component. So I won't be going to the treatment of this. Then suprascapular entrapment. So usually there's a cachexia of the shoulder girdle musculature in cancer patients. Okay, it may cause winging of the scapula, and this winging of the scapula may result in suprascapular nerve entrapment. And this is how the patients may develop the suprascapular nerve syndrome. So pain is typically unilateral, and it is worse with both upper extremity abduction and internal rotation. And it depends on the location of the nerve entrapment, where exactly is the nerve entrapment. So if the nerve entrapment is in the suprascapular notch, okay, it results in the abrupt shoulder pain affecting the posterolateral aspect of the shoulder, scapula, arm or neck. But if it is more distal at the spinoglenoid notch, it causes less pain but increased infraspinatus muscle atrophy. So based on where exactly is the entrapment, the symptoms may vary. So it can be confirmed with the pain relief procedure of the suprascapular nerve. It's a very easy procedure. Dr. Avinash will be speaking up on that, ultrasound guided. And we can also do a surgical decompression. Facial pain, again, it is also common among the lung cancer patients and can arise from several different mechanisms. So it can metastatic disease to the cranium or to the meninges or facial neural structures, including the trigeminal ganglion, may cause facial pain associated with neurological deficits. In addition, various structures in the thorax, including the pharynx, larynx, esophagus, and trachea, may cause facial referred pain via the nerve of ulnar, which is a sensory branch of the vagus nerve. Spinal cord compression, as everyone knows, the metastatic bone pain, if there is a compression, wedge-like fracture, especially in the posterior element of your vertebral body, it may cause your spinal cord compression, and it almost occurring on only about 10% of the time. It's not though very common, but it happens. And they often present initially with pain, which may be somatic or neuropathic in origin, and less than 50% of the patients will have signs of neurological dysfunctions at presentation, but may go on to develop impairment over months to weeks if it is not taken care of. So many patients feel worse with lying flat. There may be a radicular or funicular pain, which often gets worse with increased intra-abdominal pressure, that is coughing or sneezing, spine flexion or straight leg raise. And urgent consultations for radiotherapy and surgical decompression should be initiated for these patients. Just don't wait, just take their opinions. Coming to the last, the treatment-associated pain syndromes. They are related to radiotherapy, chemotherapy, and surgical therapy. Okay, these are the three commonest things which we do in our lung cancer patients. So radiotherapy related, it has been described with regard to the radiotherapy, which is delivered directly to or around the spine and the brachial plexus. So if it is an upper lobe and if you are delivering a radiotherapy, it can cause your radiation-induced brachial flexopathy. So acute and transient brachial flexopathy is known to occur either during or immediately following radiotherapy. There could be acute to subacute pain flares, which are associated with radiotherapy targeting the spinal metastatic disease also. You can see that there is a radiation flare. For a metastatic bone pair, we give a radiation therapy and there will be an increase in flare. So that we call it as a radiation flare. Again, as I previously told, it is important to differentiate radiation-induced flexopathy from tumor-related flexopathy. Tumor-related is usually associated with greater pain and Horner syndrome, and radiation-induced flexopathy tends not to cause significant pain, but occurs 4 to 5 months after the radiotherapy. It doesn't cause immediately, and predominantly affects the upper cervical nerve root. So C5, C6. That one affects C7, T1 group of the lower roots. So there could be an extremely rare presentation. Most of the commonest presentation, usually sometimes they do come with after 2 years. And when such group of patients come after 2 years, it is not usually the pain, which is very common. They have the complaints of sensory disturbances, weakness, and lymphedema more than pain. And also you should remember that it also causes osteoradionecrosis, which is also well described because of the radiation. It's very uncommon though. Pain related to chemotherapy. So we know that chemotherapeutic agents damage your peripheral nerves, and most frequently implicated chemotherapeutic agents are the vinca alkaloids, taxanes, and alkylating agents as cisplatin. It is dose dependent. It ranges from acute transient paresthesia that can subside after the treatment cessation to chronic intractable neuropathic pain. And you have to remember that there is one drug that is 5-FU, we call it 5-fluorouracil. Patients may also experience the ischemic chest pain, okay, which is thought secondary to the coronary vasospasm. So this group of patients you have to remember when if they are on 5-fluorouracil and if they complain of chest pain, it could be because of that. But still you have to rule out MI or IHT, because that is a death taking. Okay. In post-surgical pain, there is something called as post-thoracotomy pain syndrome, PTPS, we call it ICE. Okay, so it's relatively common and is seen in almost it ranges 5 to 65% of the patients after thoracotomy, because there is a huge variation of the definition. So that's why the range is too wide, because there is no classic definition of that post-surgical pain. But right now, the new definitions have really classified what is a persistent post-surgical pain and what is chronic post-surgical pain. Now we may get a decrease in the range, the new studies. So minimally invasive techniques have been offered to the patients to decrease or to increase the rehabilitative procedures, to decrease the post-surgical period in this group of patients, and to decrease the pain also. But they have found that there are no much benefits, even if you use the minimal invasive surgeries like VATS, that is a video assisted thoracic surgeries. So the choice of acute pain management techniques to prevent these post-surgical pains are, you have to give a preoperative placement and usage of thoracic epidural. This is the gold standard in this group of patients we have to use, and you will see a drastic reduction in post-surgical pain. That is what happens. So thank you very much for your, I can say, kind listening to this exhaustive talk. Okay, if you have any queries and all, you can reach me onto my mobile, or you can just tweet me. Thank you, everyone. So I think is Dr. Jain online? All right. So with this, I would like to invite Dr. P.N. Jain, who is my mentor, who was my postgraduate teacher also.